are you? Hello, everyone. Welcome to the first consecutive IMA NDB Meet. So we have completed 100 episodes on COVID, and now we are moving on, beyond the pandemic. So today, Dr. Nidhi, who has been taking on these sessions very brilliantly, I must say. She would be discussing how would a pandemic end and when would we call, when can we just say that the pandemic has ended. So, after that, we are also discussing lifestyle changes that would bring about a better immunity, a better lifestyle. Maybe it would add to our longevity, and we are going to be discussing topics like those. So I think one of the most pertinent ones in that field would be obesity, and Dr. Nidhi would also be discussing the same. So even though she does not need an introduction, but let me introduce Dr. Nidhi, who is the Secretary of IMA NDB and also the Associate Medical Director of ENT and the Head of the Safety Committee in Shroff Charity Eye Hospital in Daryaganj. She has been doing these sessions with us, and we are very grateful for the same. Today, without much delay, I would request her to come forward and start the session on the topics.
Thank you so much, Meenakshi. Very, very briefly, we'll touch upon one significant happening that happened in this last week, and that was Denmark deciding to actually boldly declare that the pandemic has ended. So the data around that. But otherwise, we'll largely be focusing on when we say the pandemic itself has ended, what really is a pandemic, and move on to obesity as our first in the series of lifestyle enhancement measures. So today we are going to be talking about when does a pandemic really end, and has this one ended? And if there is one topic that becomes very relevant, both in terms of the pandemic and in terms of the global burden of disease right now, it appears to be obesity. So that's going to be the first one that we start discussing. So, nobody has the crystal ball. We don't know when the next variant will emerge. We don't know how we should look at the population behaviors and say that, okay, now it has ended. However, certain guidelines allow us to make an educated estimate of what is happening in the world, which we've been doing over the last few months now. So you can say that a pandemic ends when the daily new cases are significantly lower than the previous 15 days, 1 month, 2 months, or a quarter. When you find that the new admissions are similarly exceedingly lower than the last week, fortnight, month, or quarter. When the excess mortality, now this appears to be one of the decent predictors. When the excess mortality that you attributed to the pandemic falls back to the baseline, when the disease does not cause economic, civic, or medical overload or overwhelm. You could also use some technical population-based statistical measures like the R0, excess mortality, and ICU occupancy. But also, we could say that a pandemic is ended when in the general population, the current situation, whatever they may be, becomes an accepted lifestyle situation. Sometimes we have declared pandemics ended when the herd immunity makes further disease amplification difficult or impossible. Variously, that has been a seroprevalence of 60 to 70%, but we have already hit 80 to 90% in this pandemic in some disease populations. So we need to look at the actual risk reduction as well as the perception of that risk to be low enough for normal civic and economic activities to go on. The key parameters then become the population immunity and population risk, the immune exposure and the available treatments, the available preventive measures, and mortality reduction. In all these parameters, it appears like the COVID-19 pandemic has ended. The disease has not ended. Let us be very clear about it. COVID-19 is here to stay. However, the pandemic emphasis has ended. So how far did this disease take us from the baseline in excess mortality? If you look at this, 21% in the US, this is from a paper which analyzed a lot of countries. Unfortunately, we didn't have Indian data in this, but if you see 21% excess mortality in US, 18% excess mortality in UK, 0% excess. You are seeing the graphs are overlapping each other, 0% in Norway. In some countries, we even had a drop from the baseline mortality. Iceland -1%, Singapore -1%, and South Korea -1%. So the very fact that these countries followed certain policies, in South Korea and Singapore, definitely it was a zero COVID policy in the beginning of the pandemic till very late. Iceland, I believe, has some other reason. We can go into that in detail if it's so. Excess mortality is deaths from all causes compared to average over the previous years. And if we look at the 0%, that's the baseline. During the pandemic, UK and US have significantly, up to the tune of 40% or even 100% in case of UK in the first wave, they have had significant mortality in excess of their baseline. Israel has been going up and down, but has been hovering around 20 to 30% above the baseline. These three countries have the best medical facilities, the best testing facilities, the maximum immunization, and perhaps also UK and US have had a parallel obesity pandemic. Israel doesn't quite fit into that data. Israel population is relatively young and relatively fit. So vaccination coverage did not help these countries combat the excess mortality, but now, as of April, all countries are coming back to the baseline. If we look at confirmed COVID-19 deaths as a share of excess deaths, so in UK, 80% of the excess deaths were attributable to COVID. In Spain, 60%. In Belgium, 110%. I don't know how that works, but well, in Italy, about 70%, Netherlands, 60%, and in France, 100% of the excess deaths were attributable to COVID-19. If we look at Indian data, in the Delta wave, we see this significant surge which took us way above our baseline. And coming back to why Denmark on February 1st decided that they are doing away with all pandemic measures. They decided on no masking, no need for crowd control. I mean, carry on as you would on a normal day. This was despite the fact that Denmark was at that time seeing an increasing number of cases of Omicron. So despite their curve being upward, they decided on the 1st of February that they are going to do away with pandemic measures. As of end of April, Denmark is at 3% of their peak and falling. On January 27th, they had 51,000 cases. A day after they removed all pandemic measures, their cases had risen to 55,000. Slight increase about a week later. But by the end of February, they had come down to 30,400 infections. And as of April, they are down to 2,042 infections. This is when they are not, they're not making any of the pandemic measures mandatory. What population does on its own is what they do on their own. Yesterday or day before, they announced that they're also doing away with vaccination and mandatory vaccination and temporarily suspending all vaccinations. They were very clear that this measure is temporary and that as the season for flus and upper respiratory illnesses arrives again, somewhere near the fall of the coming this year, they will re-look at the data, re-evaluate the need for vaccination, and maybe offer it again if needed. So if you look at how Denmark has been doing their lockdown measures, this is when their peak had not yet come. When the cases were still rising, that they opened everything up. It rose and then came down. Deaths are down a little more than the baseline, but the trend is downward. So February 1st, as we said, the daily new cases staying there, February 10th rising, and April 25th coming down. If you look at why Denmark could have made that decision, you look at the deaths trajectory. This is expected for US. The predicted for all over Europe is flatter than US mortality. Norway, Finland are somewhere at the bottom. Denmark is closely behind them. Spain and Italy are kind of close to US, but again flatter. They seem to have taken this call on a very examined, responsible, and accountable manner. So even though we keep hearing that India may be underreporting, but our excess mortality data seems to support our stand also. We don't have any mandatory measures for the pandemic right now. Our cases are rising somewhat, but our deaths are close to the baseline. If we look at the R naught, you see the values around 25th April. In India, these had risen close to 1.5 about a week ago, when we had started to see a rise. Now it is again falling close to 1. In the US, again, it is falling. UK and Israel are below 1 at the moment, which means that then for them, the pandemic is not in the propagative phase for sure. If you look at the confirmed cases, January 25th, at the peak of the Omicron wave, Israel 10,000, India 200. April 27th, this is per million. Israel 350, India 1.9, showing a rising trend, need to be on the watch. However, these trends, as I said, the virus has not gone. The pandemic, however, may be over. If you look at emerging variants, CDC has done this very smart thing of tracing variants now. And this is called Nowcas. They are finding the newer variants slowly inching up, and the previous Omicron variants slowly being moved out of the reckoning. The BA2 right now is the dominant variant, but BA2.1.1 seems to be inching up. If you see this slight uptick in the number of cases in the US, the deaths, however, are way down. Hospitalized, close to the baseline. Number of tests are staying relatively up. So they do say that hospitalizations are rising in a majority of American states, signaling that the surge is largely national in scope. However, this is still something to be watched. Now, if you look at this, the vaccination status of the country is nearly 80%, at least one dose, at least 70% fully vaccinated. They have even vaccinated 5-year-olds and up. 65 and up, what is the maximum risk for the population is 95%, at least one dose, and fully vaccinated 90%. We look at India, we are about 60% fully vaccinated and at least 73% partly vaccinated in their estimate. When we look at Government of India data, we are at about 89% vaccination coverage. On an average, in the last week, about 3,000 cases were reported in India, and nearly 50% of them were reported from Delhi. Why that is so, again, is something that we need to go a little deeper into. But looking at the previous waves, the growth, the slope is very small, but needs to be watched. In UK, if you see 75% fully vaccinated, 80% at least one dose, and on an average, they are about 15,000 to 16,000 cases every day. They have significantly, nearly 50% decreased from their average of the fortnight before. So looking at India, about 3,600 cases, 3,700 cases, the 7-day average being about 3,000. So we are still higher than the 7-day average. That means there is a very slow growth that is still being observed, but it's not rising at the rate that we saw here or here. Looking at I'm going to deal with Delhi separately, but looking at Uttar Pradesh, the new cases 218 7-day average, 216 kind of flattening out. Looking at Kerala, new cases 412 7-day average, 318, maybe a little uptick, need to be watched. Maharashtra 148 153, new cases less than 7-day average appear to be going down. Goa, new cases 6, 7-day average 6, appear to be staying close to the baseline. If you look at Delhi, out of the 3,600, 1,600 are in Delhi. If you look at Delhi's graph, the slope is not small. The slope is going to go somewhat like this. We need to watch the coming week and see if this number is going down. The deaths, however, are hovering between 1, 2, or 1. Nearly 60% of the Delhi cases are also the ones who are being detected due to other diseases, that they came to the hospital for something else and they tested positive for COVID. Delhi's last week looks something like this. On 25th of April, there were 1,000 cases. On 26th of April, there were 1,200 cases. On 27th of April, there were 1,300 cases. On 28th of April, there were 1,400 cases. On 29th of April, there were 1,600 cases. So roughly 100, 150 cases rising every day. However, the bed occupancy is actually quite small. 120, 130, 140, 150, 140. So if we look at the parameter of whether excess disease burden is overwhelming the medical systems, then there is 0% ICU occupancy and less than 2% bed occupancy, with enough medical facility available to deal with any surge that might start now. We still have to be on the lookout. We still have to be prepared. We still have to take individual measures so that we don't become part of the surge. Now, coming to obesity. Obesity is the leading cause of preventable death, and people who are considered obese are 20% more likely to die of COVID, among other things, than somebody who is fit. Interestingly, there are more overweight and obese people now in the world than normal healthy. Obesity increases your risk to heart disease, stroke, depression, diabetes, and at least 13 cancers have been found to be associated with obesity. That makes it very significant and something that we need to be looking at a little deeper. So, why should we evaluate ourselves? The global burden of disease is approximately 1.9 billion people are considered overweight and 650 million people obese. 2.8 million deaths can be directly attributed to obesity. And in India, the disease burden is not small. More than 135 million obese individuals, largely having central obesity in about 36% of the people. In 2019, according to this paper, the figures were inching up to 40%. Now, why are people becoming obese in India? We also know that the rural Indian diet, largely vegetarian, occasionally non-vegetarian, the rural Indian lifestyle, largely walking, sometimes running, appears to be protective. But with increased automation, urbanization, and focus on processed foods, with increasingly sedentary lifestyle, and perhaps an improved standard of living, what earlier was done by hand is now done by washing machines. The rural obesity also has risen from 2.2% in 1989 to 17% in 2012. So almost 3 out of 4 Indians are overweight.
We are ready for it, then we will miss the marriage on 8 because that is not a very
नहीं तो आप मेरे को बस फाइनल बोलिए, मैं अभी बोल ही दूं.
It takes about 10 years to gain that much weight, and in a very dedicated manner, if you work hard, then you would need 3 to 4 months to bring down your weight by about 10 kilos.
तो
But
Dr.
Dr. Podara,
Udar, you're getting unmuted accidentally. Please just check your system. Thank you.
so this was a nutritional survey done in 2017. In Goa, we had the largest number of adolescents who were either overweight or obese. So even childhood obesity is on the rise in India. If you look at the really obese states, you look at Tamil Nadu, you look at Arunachal Pradesh. I mean, these are the states which were otherwise, fitter states. So maximum risk appears to be in the 28 to 38 years of age. That seems also to be the time when people start focusing on their careers and become largely sedentary, do not focus on their own health, rather on their professions. The average Indian needs to lose about 11 kilos. It has taken them about 12 years to gain that weight, but it will take them at least 3 months. And I can tell you 3 months is very unrealistic. I mean, these are, of course, figures that people are putting forward, but it is very difficult to lose 11 kilos in 3 months. You have to do something really, really smart and dedicated with discipline to lose 11 kilos in 3 months. The Indian Health Ministry says BMI of more than 25 is obese, but I have a problem with BMI indicators, and that is, as you start focusing on your health and gain muscle mass, muscle being heavier than fat, you might have more weight for your height than expected from average and will classify as obese while you may not be so. So there have to be better measures to measure that, and we'll come to that in a little while. Now, prevalence of obesity in the adult obesity in the world, we till just 2 to 3 years ago were somewhere here. Right now, we are somewhere here. US has gone higher than Mexico. What this means in terms of economic burden, medical burden, and psychological burden cannot be overemphasized. Looking at the BMI formula, if you look at your weight and divide it by height square in metric, that means weight in kilograms and height in meter. In the imperial, if you were to put your weight in pounds and height in inches squared, but multiply that by 703. Essential fat in men is about 5% and in women about 13%. Athletes require about 13% fat in men and about 20% fat in women. In fitness, we would need about 17% fat in men and about 25% fat in women. On an average, you can say that a man who has about 18 to 25% fat and a woman who has about 25 to 31% fat may be considered healthy. Obesity for men more than 25% fat and for women more than 32% fat. However, as I was saying, that this seems to be a slightly skewed parameter. It appears like the waist circumference, the waist to height ratio, and the waist to hip ratio seem to be better predictors of obesity and metabolic health. Measure the narrowest part of your waist and the widest part of your hips. The women with less than 31.5 inches of waist have lowest risk. Men less than 37 inches have the least risk. Risk rises for women from 31 to 35 inches as moderate, and high risk more than 35 inches. For men, 37 to 40 inches of waist are associated with moderate risk, and more than 40 inches with high risk. Remember, however, that you are looking at an individual and you must look at what their baseline was. I mean, what were they when they were their fittest? So the waist alone, very easy to measure, or the waist to height ratio. When we say that, the waist to height ratio should be less than half, that means your height should be double of your waist. And this is a good predictor because it gives you the estimate of central obesity, which is the main driver of insulin resistance and also of the metabolic dysfunction. So waist to height ratio and the waist itself appear to be the best estimators of visceral fat and hence of metabolic health. As I said, you should measure the narrowest part of the torso and the widest part of the hips. But what can you start doing now? You can start making a change today. You know, when I did my BMI is coming to 30.1, so I'm obese. And I know for sure that I want to lose about 11 kilos of weight. I'm also fairly active. I work out 3 to 5 times a week. So there is more to it than meets the eye on single measurements. You must be aware of your own metabolic health, move a little more, think nutrients. So think macros and micros, think carbohydrate, fat and protein, think vitamins and minerals. Start thinking about what you put inside your body. Remember also that the ADEC group of vitamins is fat soluble. So if you do not have dietary fat, these cannot be absorbed. Also, if you have too much visceral fat, these will localize to that fat and not be available in circulation. So there is a nuanced dance that your body plays, and you have to be part of the determinators of that action rather than the victims of that environment. Increased visceral fat is also associated with poor mitochondrial health and poor insulin sensitivity. also associated with increased inflammation. But remember that you need to be compassionate when you see somebody who is not able to reduce that weight or reduce that fat. I have been there. You know, I was about 50 kilos when I was in college. I think about 54 kilos when I started my medical career as an active professional. With my first pregnancy, I became 62 kilos. With my second pregnancy, I became 82 kilos. And then for a while, I was not very active, and it slowly creeped up to 84 kilos. And one of my friends, also a karate trainer for my daughter, saw me after 6 months or 7 months and said, "What have you done to yourself, ma'am?" And that was a wake-up call for me. After that, I gradually increased my activity, brought it down to 75 kilos, then brought it down to 72 kilos, and then went up again. But looking at weight is not the right measure, as I was telling you, because now if I look at my muscle mass is nearly 33%, which for an average woman would be 22%. And that makes for a heavier body. It also makes for a more efficient body. You can be obese and still be insulin competent according to your BMI measures, or not be obese. You could be skinny obese and still be insulin resistant. So what are the things that you can measure to monitor your own health? I think blood sugar is a good proxy, a simple proxy for metabolic health. Occasionally, maybe once in a quarter, maybe for active diabetics, maybe once in a week, maybe every day. I don't know how you would do that. Do your fasting and postprandial blood sugar. At least occasionally also do a glucose tolerance test. But a very good proxy for glucose tolerance test is your fasting insulin. HbA1c is a good indicator of what your metabolic health has been over the last 3 months. As we know, the RBCs are have the longevity of about 3 months. And if hemoglobin has been glycosylated, it will stay glycosylated for that duration of its life. So, you know, while my BMI on calculation falls to 30.01, my fasting insulin is at a 12. My glucose tolerance test is a less than 140. My fasting blood sugar is at around 84. So all these parameters tell me that I am metabolically competent as of now. Why does the metabolic syndrome happen? What comes first? It's a chicken and egg situation. You could be under exercising or overeating. You could be loading with processed foods. But the insulin resistance seems to be the central fulcrum on which our health teeters. Do we eat more because we have nothing else to do? Are we addicted to moving our mouth? Can we create an ecosystem of health and advise our patients about something simple that they can do every day to start moving towards good health? I told you I've been there. This was the 50 kilo mark. I was very thin. This was the 75 kilo mark. This is interestingly 79 kilos. But you see the difference between this picture and this picture. It's the waist to hip ratio that becomes more important. It's your metabolic health rather than your absolute weight, which is more important. It is your level of activity and your fasting insulin or your insulin sensitivity, which is more important. I think if there is only one parameter that you have to judge your metabolic health by, that would be your fasting insulin. It can be a good proxy for metabolic health. I would request whoever can volunteer to do a talk on, how, I would love to do what insulin does in the body and how it changes with various metabolic states. But, insulin management of diabetics is something which is very, very special. And I think one of the physicians or endocrinologists or somebody who's really doing it every day should give us some rules. Like sir used to give the rule, कि double kar do, half kar do, which is something that I don't have that bandwidth. So I'm going to stop here and allow you to digest what I have said without raising your sugar levels to the level that they trigger insulin. I think the next talk should be insulin, and I think we should look at insulin in health and disease because it seems to be the central fulcrum of health.
Brilliant talk, Dr. Nidhi. So just today in the Bhagavad Gita session, we have talked about how leading by example is key to, a good speaker. And I think you've done just that today. So thank you for sharing these with us. Obesity, I had read somewhere that before the COVID pandemic had hit us, there was a bigger pandemic that we were dealing with, and that was the obesity pandemic. And we, very rightly, right after, our COVID talks, you started with this topic. And I think, again, brilliant points put forward by you. So the floor is now open for questions and discussion. So if there's anyone who would like to share something or discuss something or ask any questions, we'd be happy to hear.
Madam, what are the 13 cancers you have narrated? And can you enumerate?
I can't enumerate 13, but I can tell you CA breast is associated with obesity. Pancreas is associated with obesity. Some of the gut cancers are associated. Colon is associated with obesity. So I can't enumerate all 13, but there is a CDC presentation on this, and even Alzheimer's has been, and one of these astrocytoma or something, even a central nervous system cancer has been associated with obesity. Even Alzheimer's has been associated with obesity.
CA, endometrium and ovary also.
Ovary also, yeah.
Breast and ovary.
Yeah.
Also,
I have a question.
Ask
Yes,
you,
ma'am.
Dr. Nidhi, or maybe discuss why Delhi is behaving, almost
the way it is behaving.
half cases in Delhi. Is it a possible new strain or what is wrong?
We don't do strain testing, so I can't say. But from what I'm seeing in the clinic, people are still coming with severe pain throat and possibly pain abdomen.
Correct. Little feverish or fever or
fever is not their presenting problem. I mean, they come with severe pain throat largely. Fever nahi ho raha hai itna. So mere ko ye lag raha hai ki it is still Omicron. Which variant? we are not doing the testing. If it is Omicron, and there are studies that have come out of Israel as well as from UK and US, which and Denmark, which say that the reinfection rate after Omicron is less than 10%, to 7% to be exact, which means अगर आपकी zero prevalence is 90%, तो ये 90 तो safe है.
So this comes from combined hybrid immunity plus
Yes.
or recent COVID, maybe within 3 months, ऐसा कुछ Omicron.
Maybe, but as I said, nearly 50% of the national burden seems to be coming from Delhi, which is a matter of concern.
Right.
What we can do is we can take care of ourselves and people who come in contact with us. But why this is happening is something that needs a little more and a little deeper work.
We are going in for mass parties, gatherings.
Yes.
Are off.
This is what I've seen, even in doctors' meeting, I've seen that people were unmasked and they were socializing, sitting together. So that must be the reason. I have a question that
Yes,
we
ma'am.
should get fasting insulin done.
Yes, ma'am.
In routine test.
I think so, ma'am.
And what is the normal value?
Less than 25.
Okay. Thank you.
So fasting sugar less than 100, fasting insulin less than 25.
Okay.
Even in PCOD also, insulin, basic insulin will help, no?
Yes.
PCOD, yes, but people like, we are going, senior citizens, we are going for our test, so we must get the insulin also done.
Ma'am, मेरी जो fasting insulin है ना, वो throughout the pandemic, it has stayed around 10, 12. Once it has even gone down to 8. So I would say that it is a very good proxy for metabolic health. And if you have a good fasting insulin, you should not be very much bothered about the absolute weight that you're carrying, so long as your waist to height and waist to hip ratios are fine. My waist to height and waist to hip ratios my waist to height ratio is less than 0.5 and my waist to hip ratio is around 0.72. So it should be less than 0.8.
So
Madam, why the fasting insulin is preferred?
Fasting insulin is preferred because it tells you how sensitive. So the body is going to produce insulin if it senses the need for it. And for people who are insulin resistant, the baseline levels of insulin are high. So if you do a fasting insulin, it tells you what is your insulin sensitivity.
Madam, you have mentioned about the BMI. If the BMI is less than 40, then is there any risk for the metabolic syndrome?
So that's what I wanted to bring out, that you can be fat obese or skinny obese, and largely this is determined by the insulin sensitivity. There is some essential fat needed for some vitamins to work, the ADEC group. If the fat is too much, then insulin resistance creeps in. So there is a balance which needs to be maintained. And skinny fat is a thing.
If I mention you that my BMI is less than 40 and I have no diabetes, I am pre-diabetics and I am running 71 years.
Sir, आप ना एक model हो.
Yes.
You are an example to follow.
Actually, many obese people who are highly obese, like more than 35 BMI, I've seen many who are not diabetic, not even hypertensive. So it's very confusing sometimes to see such people, but they are vulnerable. Yes.
So what I would say is then you should check their fasting insulin and see whether their insulin sensitivity is maintained, because that seems to be the fulcrum on which their health is resting.
And
Insulin
madam,
is
what are
the
the
only
criteria for the
culprit for all
childhood?
metabolic diseases, you know.
Ji sir?
Madam, what are the criteria for the childhood obesity for BMI?
सर मेरे को ये तो देख के ही बताना पड़ेगा, अगर मीनाक्षी ऑफ हैंड बता सकती है तो. Childhood obesity, I think parameters stay the same, but I am not sure.
Okay.
So about insulin, sir used to say that a fit person, the insulin. So you know how sir had his own formula and his own normal
Yes.
for everything.
Yes.
He used to say that insulin levels less than 10, like that's what you should have if you are really fit, and that is what you should aim. And he used to say that don't look at the normal ranges in the reports. And you know, I think that's pretty much, you know, as you said, that throughout the lockdown you came back. So another you know, feather in your hat, I must say, because yes, that is what sir used to say, that that's what we should strive to get, an insulin sensitivity of 10. Just 1 second. So childhood obesity, I'm just I'll just pull it out of the internet if you know, for the sake of completion. But in the meantime, if there's any other question, I think Dr. Sanjeev Agarwal has also mentioned that there is diarrhea, which I am also seeing. And Dr. Nidhi, I am seeing fever. I am still seeing a lot of 100. You know, in fact, in this very short period, I've also seen one case of pneumonia, COVID pneumonia. I have seen one. It's established pneumonia, and you know, I'm seeing temperatures of 102, 103 as well. In almost every patient.
So I have seen in the last week, I think 3 or 4 patients, and significantly there was no fever.
In diarrhea, are you giving
severe
antibiotics these days, like Zenflox, Oz?
No, in fact, I never gave it for a viral diarrhea. I never gave it.
Yeah.
We might, if there is severe diarrhea, I might just give the gut antibiotic rifaximin, but that is if it is you know, going on for 2 to 3 days. You know, that's depending on the patient, of course.
Zinc drops
in COVID. Sorry.
Zinc drops we can give. Zinc drops.
Yes, zinc drops can be given.
Zinc drops can be given. Yes.
Ma'am, I had started doxy and ivermectin in a patient I saw on her 6th day of fever. In between, the fever had gone down. It came back again along with the other symptoms of COVID. His wife was positive, he was negative, and he was unwell. Cough was also more. So I had to start this next step. Otherwise, his wife, nothing, no antibiotic. Ivermectin I gave, yes.
Yes.
Zinc, vitamin C, D.
So I would say that our protocols don't change too much, but I'm not starting doxycycline immediately. I wait for 2-3 days to see how the patient is doing. I do get the counts. If the counts are high, then I start doxy. But I do the rest. So mefenamic acid, antihistaminic, both H1, H2, and ivermectin and vitamins B, C, D. So this I'm doing for everyone. And I wait till the 3rd day. If the patient is better, then I don't prescribe antibiotic. If the patient is not better, then I do. Or if the counts are approaching 10,000, then I do.
A 6-day fever, definitely with cough and, you know, little bit of difficulty in speaking. Can be started.
So as I said, I'm not seeing so much fever, which is why I'm maintaining this. If I saw fever, I probably would.
Are you seeing lymphocytopenia?
Not significantly, not yet.
I don't know, somehow I'm getting all these patients that are showing lymphocytes. So maybe, you know, these are the patients who are having fever and a little more severe forms of disease. So they are presenting with lymphocytopenia. Yeah. So if you're
not
not
significantly. So it's like 65-35, which is like still not.
No, I've seen levels of 14, 17, 19.
Yeah. So
Okay.
I've not seen that.
Okay.
Maybe one patient I saw, yeah, but not significantly.
I have seen about 5 patients with very high grade fever,
Okay.
104 or above.
Okay.
And
And they
was a
tested positive?
Sorry?
They tested positive?
Yeah. Positive
Okay.
cases only I'm talking about.
Okay.
Uh,
So
there
as
was a
Meenakshi is
question
saying,
there was a question regarding childhood obesity. We take it more than 3 SD.
Okay.
Then we take it as childhood obesity. Weight more than 3 SD.
Okay. But as I was saying, ma'am, कि अगर आपने fever देखा है तो as Meenakshi is saying that she's even seen a couple of pneumonia patients. So
I haven't seen any pneumonia patient.
I've seen one pneumonia patient.
Hmm.
And no, of course, it's not very severe. Or it was 4/25, but yes, it was there. Just one in the last few days, but yeah, a lot of lymphocytopenia cases, a lot of high CRP cases, but the high CRP,
yes,
not requiring steroids.
Yeah.
Settling down on its own.
Settling down, yeah.
If CRP is high, we have to bring it down to take the booster.
मैम जो हम एंटीहिस्टामिनिक्स देते हैं और जो हम मेफेनेमिक एसिड दे रहे हैं in patients with moderately high CRP, this will come down. If there is a bacterial superinfection, then we expect CRP to start rising again. That is when we would add an antibiotic.
And colchicine?
Colchicine, if it continues to stay, colchicine, if it continues to stay high. Meenakshi, correct me if.
No, I agree. So again, I'm seeing all these patients who are coming in with fever of 102, 103 on day 1, day 2. Sometimes it comes up on day 3. So I'm starting colchicine there. That's been the protocol. So I'm just trying to follow that. I honestly I was giving colchicine twice a day earlier in the previous phase, but I have reduced it to once a day now because I'm seeing that the inflammation is settling down on its own without doing much. So, even I don't like prescribing too many medications. So I've reduced it and I'm just watching the pattern, and I might as well use the colchicine as well, because I think mefenamic acid in itself, helps to fight the CRP.
So interestingly, when you were prescribing twice a day, I was doing once a day. And now you're doing once a day and I'm not prescribing.
Yeah.
So
I think
so. So do we have a volunteer for OPD management of diabetes? No?
PD management, you mean right now?
नहीं, अभी नहीं ma'am. मतलब we are going to, I think I would like to do what insulin does and I mean how it works, but clinical use of insulin is something that is a specialized topic. I think that a physician should do.
Then you need a volunteer who's taking insulin.
Either taking or giving.
Taking or giving, or we can, start insulin on that patient.
Yeah.
Willing to take.
Yeah.
I can volunteer, but I'm not taking insulin.
I can request Dr. Sanjay Kalra to maybe take one of those sessions, and we can see how that moves forward.
Sure.
That's something we can plan that out. So I think that would bring us to the end of our show today. Thank you everyone for joining in, keeping this show alive. And a big thank you to Dr. Nidhi for working so hard for these Sunday morning sessions. We're grateful to have you among us. Thank you. We'll be back next week. Until then, goodbye.